Hello, everyone, and welcome to tonight's presentation, Highlights and Takeaways from Thought Leaders, the EndoVators Summit on Obesity. This webinar is sponsored by the Association for Bariatric Endoscopy, or ABE. I'm Gina Steiner, ABE Director, and I will be your moderator for tonight's call. Your presenters for this evening are Dr. Michael Larson, Dr. Shelby Sullivan, Dr. Marvin Yu, and Dr. Nitin Kumar. All serve on the advisory board for ABE. Dr. Larson is a therapeutic endoscopist at Virginia Mason Medical Center in Seattle, Washington, specializing in bariatric endoscopy. Dr. Sullivan is Director for Gastroenterology, Metabolic, and Bariatric Program and Associate Professor of Medicine at the University of Colorado School of Medicine. Dr. Yu is Assistant Professor of Medicine at Harvard Medical School and co-director of Bariatric Endoscopy Fellowship at Brigham and Women's Hospital. Dr. Kumar directs the Bariatric Endoscopy Institute for Gastroenterology and Weight Management in Addison, Illinois. At this time, I'd like to turn the webinar over to Dr. Yu.
Thank you, Gina, and hello to all of our webinar participants. I'd like to start with a little background on the EndoVators Summit, which was held in late November in 2016 at the IT&T Center in Downers Grove, Illinois. The overarching goal of the summit was to foster discussion to better define the role and value of endoscopic therapies in obesity management. And to this end, we had over 100 obesity management experts, innovators, and key decision makers from throughout industry, various payer groups, and regulatory agencies assembled to foster this discussion. We also had leadership representing multiple medical and surgical subspecialties, including the ones that you see here. In addition to the ASGE and the ABE, which hosted the EndoVators Summit, we had society representatives from various surgical subspecialties, including ASMBS, IFSO, and SAGES, as well as leadership from AASLD, ACG, even the Obesity Society, the American Society of Transplantation, and the Academy of Nutrition and Dietetics. So a broad swath of groups were represented at this summit. The summit was organized into the following 4 sessions as shown here. We started with session 1, which aimed to provide an overview of the obesity problem, discussing the epidemiology, etiology, and impact on public health. Session 2 covered how we should treat obesity, components of a successful program. Session 3 entailed endoscopic treatment of obesity, and session 4 concluded with the nuts and bolts of reimbursement. There were multiple lectures for each session by content experts, and my colleagues and I today will attempt to accurately summarize these lectures. So with that, I will turn the mic over to my colleague, Dr. Mike Larson.
Thank you, Marvin. So I'm going to cover, hello everybody. Tonight I'm going to cover session 1 for everybody. For me, I think session 1 was actually probably the most interesting because as a gastroenterologist, it covered a lot of stuff that's sort of outside our standard practice. The EndoVators Summit was really a great event as it brought together people from lots of different fields, both inside and outside of medicine. So I hope you guys will enjoy hearing the summary. I really enjoyed the summit. It was a great day with a lot of learning. And so we'll try to cover as much as we can. The first session was moderated by Dr. McQuaid, who's our ASG president. And there were three speakers in session 1. So you'll see my slides are broken up by each of the different speakers. So the first speaker was Dr. Dietz, who came from George Washington University. And he is the chair at the Redstone Global Center for Prevention and Wellness. He spoke about the obesity epidemic, implications for public health and the healthcare system. It was a great talk. He sort of set the stage for everybody afterwards. He described obesity as a chronic relapsing disease and suggested that what would be better than referring to patients as obese people is to talk about it as people with obesity, which makes a lot of sense when you think of it as a disease. He pointed out that obesity has a staggering worldwide presence with a very high obesity rate, particularly in the U.S., where more than 37% of people now have obesity. He said that there are some positive signs recently in terms of the epidemic stabilizing, possibly secondary to preventative efforts. Some of the positive signs include when you look at rates of obesity in men since 2004, there's really been no increase, so we've been stabilized there. Another area where things are looking better is in small children, where kids between age 2 and 5 are actually decreasing in the rates of obesity. So possibly some things are improving. But there are still concerning signs regarding the obesity epidemic. Some of those are the continued increase in severe obesity. So BMI greater than 40 is severe obesity, and those rates continue to grow. We now have more than 10% of women have severe obesity and more than 6% of men. While the rates in men have stabilized, the rates in women continue to grow as a group. And another concerning feature was that the rates of obesity are continuing to go up in people between 20 and 39, which is an important age group because their obesity tends to affect that of their children, and that's sort of the prime age group for having kids. He talked a little bit about ethnic differences in obesity rates, which are significant. That was covered a little bit more by other speakers. And then there's some complex issues around socioeconomic status. For instance, your socioeconomic status only seems to make a big difference in white women and not other groups. And we'll talk a little bit more about that again later. Then he talked about cost of this epidemic and how it's increasing. You can see here on this slide that in 1998, the medical costs associated with obesity was only about $78 billion, but over the next 10 years, that's almost doubled. This is primarily because of that increase in severe obesity that I talked about a little bit earlier. It seems that the more obese you are, the more you're going to cost in terms of medical care, and that's primarily because of comorbidities. About 25% of severely obese patients will have more than 6 associated comorbidities. He mentioned that up to 260 different comorbidities are now linked to obesity, so there's a long list of possibilities. The overall rates of patients with more than 6 comorbidities has also gone up significantly over the past couple decades. So that's really what's driving the costs, are the comorbidities. He then moved on to talking a little bit about sort of big picture where we need to go in terms of treating the obesity epidemic, stating that we need to focus on widespread scalable strategies, that education and primary prevention are going to be key. He mentioned that the CDC is targeting some specific things to aim for, is trying to treat the bias and stigma that are associated with obesity, because these tend to prevent people from getting treatment. One important thing is going to be reducing sugar drink intake. We'll talk more about that later. Decreasing high energy foods like pizza, fast food, decreasing television time, increasing the amount of sleep, increasing physical activity. And then he talked again about focusing on that important age group of people who are between 20 and 39, because if you can get them to lose weight, often their children will lose weight through a sort of a halo effect, which is similar to the effect you see when a family member undergoes bariatric surgery. Their family members also tend to lose weight. So that was the first talk. Moving on to the second talk in this first section. This one was done by Dr. Montzoros from Harvard Medical School in Boston, and he talked about weighing the importance of genetics metabolism, environment, and psychology. So a little bit at trying to understand where all this obesity is coming from. He broke it up into sections. First, he focused on the impact of your biology, and certainly biology has an impact on the development of obesity. There is some sort of genetic component to it. There's 3 areas in the brain that are responsible for obesity or play an impact in obesity, and those include the hypothalamus, the reward system, which is particularly affected by depression, and then the cortex as well in terms of your decision making. And there's multiple hormones, many of which come from the GI tract, which impact obesity, and those include leptin, ghrelin, GLP-1, insulin. There's many being studied that have impacts on the brain, and these affect the desires to eat versus not eat. And as I said, most of these are secreted by GI tissue or GI organs or adipose tissue. GLP-1 in particular, he focused on a lot in his talk. It has a lot of effects on the GI tract. One thing it does is increases insulin, and it decreases gastric emptying. Genetics themselves do also impact obesity, and there are some very rare mutations in some of these hormones like leptin and other pathway genes, but it seems that those kinds of mutations only seem to account for a very small part of obesity. Most of the genetic impact is in a polygenic contributor. I think he stressed that environmental factors really seem to have one of the most important effects on obesity. Many factors are driving in our society are driving patients towards obesity. Some of the things that he focused on were increase in portion size, inactivity, and an increase in ingestion of sugars, which went up quite a bit between the 70s and the 2000s. The average amount of sugar intake per person increased from about 277 calories to 388 calories per day. The other thing he mentioned is an increase in television watching, which has gone up over time as well. So the environment's really driving obesity as well. And then he talked quite a bit about liraglutide, which is a FDA-approved medication, GLP-1 analog, which is a treatment for obesity, and mentioned that many other hormones are also targets for obesity, and GLP-1 will be covered more liraglutide will be covered more in later talks. He mentioned that some research that might improve the medication delivery might be helpful, because a lot of these are peptides. They need to be injections. So people are working on developing orally absorbable peptides and depot injections to try to facilitate these kinds of advancements. So the third and final speaker in the first section was Dr. Dean Schillinger from University of San Francisco, who works with really vulnerable populations. He works at the San Francisco General Hospital specifically as part of the UCSF system. He talked about the impact of the socioeconomic status of patients and their race and ethnicity on obesity in the U.S. So he talked about what he called vulnerable populations, which are populations with increased risk of obesity because of social, economic, political, structural, and historical forces that are sort of affecting them. And some of the examples he gave: a non-high school graduate will have a higher average BMI than college graduates. People with the lowest income have higher average BMI than the highest income. And national trends of BMI as a function of their education has been widening over time. And there are higher rates of obesity in uninsured and publicly insured as compared to patients with standard insurance. So there seem to be differences in socioeconomic status, but the relationship is actually very complex. It's not as straightforward as you would think. For instance, in men, there's really no significant difference in obesity based on race or income. In women, there are clearly higher rates of obesity in African Americans and Hispanics. whereas in children, there's a gradient of obesity by poverty level among whites, but not in African Americans and Hispanics. And there are multiple mechanisms that link social vulnerability to obesity. He focused a lot on his talk about the Farm Bill, and that this was really a important factor in development of obesity. This was back in 1973, and it relates primarily to food subsidies. Basically, the government decided to subsidize the production of corn, soybeans, wheat, rice, dairy, and livestock. And this had a pretty profound effect on the diet of Americans, with now more than half of the calories consumed by American adults between 2001 and 2006 coming from these kinds of subsidized foods. Problem is, these foods are on their own not terrible, but they are usually converted into high-fat meats, dairy products, refined grains, and high-calorie drinks and processed foods, all of which contribute to obesity. Because these foods are less expensive, they get purchased disproportionately by patients who use food stamps, so further leading to the gradient in socioeconomic status and obesity. He talked about something called food insecurity, which affects about 40% of U.S. families below the poverty line. What this is basically people who aren't always sure they're going to be able to get food. So they have times where they can get food and other times where they can't get food or they can't get good food. And what this does is, in the times where they have food, they will overcompensate for the times where they didn't have food and eat a lot more and have overconsumption, and actually, which leads to weight gain. They end up eating less expensive foods that are calorie dense at the expense of any fresh fruits or vegetables. He also focused a lot on sugar-sweetened beverages, which everybody at the summit really saw as a focus point that we should try to target, because sugar-sweetened beverages contribute to obesity beyond just the amount of calories that they have. So it seems to be a significant driver, and the intake of these beverages has gone up over time. It seems that the health literacy of a patient affects how much sugar-sweetened beverage he's going to intake. And the other factor has been the price index of fruit and vegetables has gone up over time, whereas the price of carbonated beverages or sweetened beverages has gone down. So more and more people with less money are drinking more and more of these sugar beverages, which are really contributing to the obesity epidemic. The last thing that he talked about was the impact of the neighborhood in which one lives and how it has an impact on obesity. People who live in deprived neighborhoods have higher BMIs. This is likely for various reasons. One is decreased exercise because of poor, not very good walkable streets. They're surrounded by violence, so they're probably not going to want to go out for long walks, and limited access to grocery stores and healthy foods. And they have a poor social network that models unhealthy diets and lifestyles. So that's the end of session one. Now I'm going to turn it over to Dr. Shelby Sullivan, who will be covering session two for everybody.
Thanks, Mike. So now we're going to talk about how should we treat obesity. And we'll start out with the talk that was given by Dr. Robert Kushner, who's the medical director of the Center for Lifestyle Medicine at Northwestern Medicine in Chicago, and is also professor of medicine at Northwestern University Feinberg School of Medicine. The talk is Exercise, Nutrition, and Medications. So Dr. Kushner really focused on obesity as being a patient-centered disease and reminded us that most patients have tried other treatments prior to seeking medical care, including self-help books, the internet, commercial weight loss programs, including Weight Watchers, over-the-counter medications, and dietary supplements. Patients and clinicians really have to recognize that obesity is as a chronic disease and is a chronic disease, and that, again, these patients will have tried multiple things before coming in to see you in clinic. There are multiple obesity treatment guidelines, but the 2014 obesity guidelines from the American College of Cardiology, American Heart Association, and the Obesity Society really are the guidelines that we look to at this point for guidance in terms of lifestyle therapy, pharmacotherapy, and bariatric surgery. Endoscopic bariatric therapy was not included in these guidelines. But that is because these guidelines were developed before the first procedure and devices were actually approved for use. The figure that's in the slide is the treatment algorithm that is included in the 2014 guidelines. It's a little bit of a busy slide, but really what you can see is that there's multiple different decision-making points, and it really lays out a pathway for being able to treat patients with obesity. One thing that I wanted to point out is that although endoscopic bariatric therapy is not contained within this obesity treatment guideline, there are points that endoscopic bariatric therapy would fit into, and that includes patients that need adjunctive therapy. So if patients met a criteria for needing a pharmacotherapy in general, if that patient had a BMI above 30, they would likely also meet criteria for an endoscopic bariatric therapy. There are other recommendations from the USPSTF, the AACE and ACE obesity guidelines from 2016. There are also metabolic surgery guidelines, which review more on bariatric surgery and also follow-up of bariatric surgery patients. And then the endopharma management, which really was a nice detailed review of pharmacotherapy for patients with obesity. So the model for management of patients with a BMI of greater than 25 kilograms per meter squared, and again, this is pre-endoscopic bariatric therapy, includes a base of lifestyle modification, which is the foundation of treatment. And all other therapies should be considered adjunctive, including bariatric surgery. And lifestyle modification includes diet, physical activity, and behavior modification. Anti-obesity medications are used for patients with a BMI of greater than 27 kilograms per meter squared with obesity-related comorbidities, at least one obesity-related comorbidity, and for a BMI, or patients with a BMI of greater than 30 kilograms per meter squared, and in that case, they don't need an obesity-related comorbidity. Obesity surgery is reserved for patients who have a BMI of greater than 35 kilograms per meter squared with an obesity-related comorbidity, or a BMI of greater than 40 kilograms per meter squared without the need for an obesity-related comorbidity. And the endoscopic bariatric therapies, again, are going to be reviewed in the next section. So this slide was not actually included in the presentation, but it is a slide that that is one of my slides and reviews the pharmacotherapy for obesity. This was discussed, and these medications were discussed during the talk by Dr. Kushner. The medications that are included for long-term use include orlistat, lorcaserin, the combination phentermine topiramate, the combination naltrexone and bupropion, and liraglutide. Phentermine, benzphentamine, diethylpropion, and phendimetrazine are medications that have been approved for short-term use and have not been approved for long-term use. Now, having said that, phentermine is approved for long-term use in the combination medication, phentermine and topiramate. One thing to just note about that is that phentermine as a standalone medication was approved for use in 1956, and at that time was studied in a trial that only lasted 3 months, which is why it only has a 3-month indication. And we'll see if I can advance. There we go. So in terms of the weight loss with obesity medications, there's a range of weight loss that you can get with these medications. So with orlistat, you're looking at weight loss of somewhere between 5 and 10% total body weight loss. Lorcaserin is somewhere between 4.5 and 5.8%. The combination of phentermine and topiramate are between 5.1 and 10.9%. And of the medications that really has the highest amount of weight loss, naltrexone and bupropion between 5 and 9.3%, and liraglutide at 8.0%. The next column looks at the percent of patients who achieve 5 or more % total body weight loss and 10% or more total body weight loss. It's important to remember that 5% total body weight loss is considered a successful weight loss for patients. Now, having said that, there are additional benefits for patients who lose more weight. So those additional benefits at more than 10% weight loss include increased skeletal muscle insulin sensitivity as well as hepatic insulin sensitivity. And there are other beneficial effects that are non-metabolic related as well. But what you can see is that for the medications, there's really between 35 and 72% or 73% of patients lose at least 5% of baseline weight, and somewhere between 13.5 and roughly 50% of patients are able to lose more than 10% of their baseline weight loss. And the medication that has the highest response rate is the combination of phentermine and topiramate, which the trade name for that is Qsymia. There are some contraindications for these medications for orlistat that includes chronic malabsorption or cholestasis. For lorcaserin, again, pregnancy, renal insufficiency. Qsymia or phentermine and topiramate is pregnancy, being on an MOA inhibitor. An MOA inhibitor, being currently breastfeeding, cardiovascular disease, hyperthyroidism, glaucoma, and of course you want to avoid abrupt withdrawal, though that medication does need to be tapered off. Naltrexone and bupropion, again, pregnancy, MAO inhibitors, end-stage renal disease, uncontrolled hypertension, seizure disorder, or a history of seizure disorder. Also, patients who would need to be on narcotic medication should not take naltrexone, bupropion. And for liraglutide, a history of thyroid cancer, gastroparesis, history of pancreatitis, or type 1 diabetes. And for the obesity medications, maximal effectiveness only occurs with lifestyle therapy. Again, lifestyle therapy is the foundation of all of the adjunctive therapies. If a patient has less than 5% total body weight loss at 3 months, the patient is considered a non-responder and the medication should be stopped. Medications must be continued long-term for continued weight loss benefit, and many insurance companies at this point do not cover the cost of weight loss medications, so it's something to take into consideration when prescribing these medications. The next talk was by Dr. Bonnie Spring, Director of the Institute for Public Health and Medicine within the Northwestern Medical Center for Behavioral and Health, where she is also professor for preventative medicine, psychiatry, and behavioral sciences. And she talked about the importance of behavior modification. So behavior modification provides patients with tools for self-regulation, self-management, and habit modification. It supports positive changes in diet and exercise and requires extensive contact with trained interventionists. Intensive behavior modification, which is defined as at least 14 visits in 6 months and monthly after, is strongly associated with weight loss and has more modest impact on weight loss maintenance. There are predictors of weight loss and weight loss maintenance among the different components of behavior modification. So self-monitoring, which is essentially a patient being able to monitor their own food intake and activity, impacts weight loss. And it's been shown in multiple studies that self-monitoring with food and activity logs is important for weight loss. Conversely, exercise is really important for weight loss maintenance. And the figure that I've shown here on the slide really demonstrates that. This is from the Look Ahead trial, which is a trial of over 5,000 patients that were randomized to either typical therapy or intensive lifestyle therapy for weight loss. These patients all had diabetes, and the average weight loss at 1 year was 8.6%, and at 4 years was 4.7%. This data comes from the 4-year time point, and what you can see in panel B is that the patients who lost more than 10% total body weight loss and were able to maintain that out through year 4 had significantly more exercise compared to those who had 5 to 9.9%, or 0 to 4.9%, or those who had gained weight. Conversely, in panel C, you can see that there is very little difference between the patients who lost more than 10%, the patients who lost between 5 and 9.9%, and the patients who had 0 to 4.9% weight loss in the total amount of calories that they were eating. There was no statistical difference between these 3 groups. There was a higher intake of calories in the group that had gained weight, but again, no difference in the groups that had lost weight. In And this really highlights the importance of exercise for long-term weight loss maintenance. Dr. Spring also talked about new technology, which can help overcome the barriers with behavior modification. So in-person visits for behavior modification are definitely a barrier for some patients because, as you can imagine, 14 visits in 6 months is at least twice a month visits. And if you have patients who are coming from far away or patients who have a busy work and life schedule, it can be very difficult for those patients to actually come in for those visits. New technology may lower those barriers. So mobile apps with real-time decision support are helpful. Of course, the self-monitoring, and there are multiple apps that can be used for self-monitoring. SmartPeople.com, MyFitnessPal, there's multiple other ones as well. And then there's also remote contact, and that can include things that are done over HIPAA-compliant connections over the internet, and also can be done by phone. Now, the behavior modification principles are the same, regardless of what kind of therapy you're giving, whether it's in person or whether it's using some of these technologies. It's still centered on trying to change and modify behaviors. The next talk was on surgical management of obesity and diabetes, and this was by Dr. Osama Hamdi, who's the clinical investigator and attending adult endocrinologist at the Joslin Diabetes Center, as well as an assistant professor of medicine at Harvard Medical School. This talk really focused mostly on the program at the Joslin Diabetes Center, which is called the Why Wait program. And this is an aggressive lifestyle management that's used to prevent, improve, and potentially cure diabetes. And with this program, they have actually demonstrated that they've been able to put people in remission for diabetes with this comprehensive, intensive weight management program. And the other important thing to note that obesity and type 2 diabetes are really closely linked diseases. The program components of the Why Wait program include dietary changes, physical activity, and behavior modification. Again, going back to that whole importance of behavior modification and change behaviors that prevent weight loss or keep somebody from losing their excess weight. In this program, this non-surgical management was determined to be cost-effective, despite the fact that these patients required the intensive lifestyle therapy, which is expensive. But when you look at the amount of insurance dollars that are spent on caring for patients who have diabetes, which is in many cases at least $5,000 to $6,000 more per year than someone without diabetes, it is cost-effective to do these kinds of therapies for patients, especially if it puts them into remission from their diabetes. The next talk was bariatric surgery, optimal patients, preferred options, and outcomes. And this talk was by Dr. Bipan Chand, who is an associate professor for gastrointestinal and minimally invasive surgery, as well as the director of the Center for Metabolic Surgery and Bariatric Care at Loyola University Medicine. So bariatric surgery leads to durable weight loss. And this is one of the first points that Dr. Chand made. I'm showing you data from the most recently published randomized controlled trial called the Stampede trial. And the 5-year results were just published recently in the New England Journal of Medicine. And what they showed is that the weight loss that these patients achieved in this randomized controlled trial demonstrated that there was significant weight loss that was maintained, even though there was some weight regain. So there was significant weight loss that was maintained at 5 years in patients who had gastric bypass or sleeve gastrectomy compared to patients who were in the lifestyle therapy alone group. There are multiple different surgeries that are currently being performed in the United States for bariatric surgery, the most common of which are sleeve gastrectomy and Roux-en-Y gastric bypass. And in fact, sleeve gastrectomy has now become one of the most common surgeries, even more common than Roux-en-Y gastric bypass. Adjustable gastric banding is now infrequently performed, but we still need to know about it because there are a lot of patients who still have adjustable gastric bands in place. And biliopancreatic diversion is also infrequently performed in the United States. Indications for bariatric surgery include a BMI of greater than 40 kilograms per meter squared, or a BMI of 35 to 39.9 kilograms per meter squared, and a life-threatening cardiopulmonary disease, severe diabetes, or life impairment. Patients also need to have failure to achieve adequate weight loss with non-surgical treatment. Dr. Chand also talked about complication rates, specifically that complication rates are comparable to cholecystectomy, and that there are nutritional deficiencies, but these can be corrected with proper monitoring. I'm showing you data from a publication from JAMA Surgery in 2014. This paper came out of Washington University School of Medicine, and what they demonstrated was that there were really low rates for mortality, both 30-day mortality and greater than 30-day mortality in all of the surgeries, and really, as a whole, less than 0.4 total, but the range really being 0.08% and 0.4%, so quite low mortality rates. Complication rates, which was a composite of all the medical complications that can occur, was at 12 to 21% for gastric bypass, 7 to 13% in adjustable gastric banding, and 8.9 to 13% for sleeve gastrectomy. Reoperation rates were also quite low, with the rates being 2.56% to 12.2%, depending on which surgery you looked at, with gastric bypass and sleeve gastrectomy having significantly lower rates for the need for reoperation compared to adjustable gastric banding. Metabolic improvements can also occur with bariatric surgery, and Dr. Chan pointed out in particular diabetes. Again, this Stampede trial 5-year results was published after Dr. Chan gave his talk, but I wanted to include that just to highlight the fact that even in this trial, 5 years out, there was significantly better improvements in hemoglobin A1C in the sleeve gastrectomy and gastric bypass patients compared to the intensive medical therapy alone patients, which is a significant thing, and it's important to remember that bariatric surgery is at this point the most effective treatment for diabetes, and is more effective than the current individual medications. Combination medications can bring down hemoglobin A1C, but you can see with this trial that with intensive medical therapy and multiple medications being used, you still can't reach the improvements in hemoglobin A1C that you can with bariatric surgery. So the next talk was actually given by me, and it was how to establish a collaborative program. So successfully treating obesity really requires a collaboration, and this is between multiple people. And again, when we think of, I like to think of obesity treatment as a pyramid, with lifestyle therapy as the foundation or basis of all the therapies, and bariatric endoscopy and pharmacotherapy kind of in the middle row, and then surgery at the top. So we've got surgeon, endoscopist, physician extender or nurse, endocrino or obesity medicine physician, registered dietitian, exercise specialist, behavior coach, and psychologist, which are really important for all of the components of weight loss, but don't have to be all specifically in the same center. There definitely can be things that are done within a type of virtual center where you're referring patients. We also, in this talk, I really talked about how patients can flow from one practitioner to another. And when we first looked at proceduralist and obesity medicine endocrinologist specialists, we're looking at the proceduralist or endoscopist who's doing a procedure, but there may be a need for the patient to have additional weight loss and may need weight loss medications. And if the proceduralist is not comfortable with that, they can certainly refer patients back to the obesity medicine specialist or endocrinologist for escalation of care and management of comorbidities. In addition to that, they may be referred back for maintenance of care. So when we look at a lot of the self-pay packages for the endoscopic bariatric therapies, these are typically a year long. So after that year is up, really the endoscopist is required to either continue to see those patients or to refer those patients to a clinic where they can be seen long term. Also, escalation of care in the other direction. A patient who is being seen by an obesity medicine specialist or endocrinologist may need to have additional therapy, like an endoscopic bariatric therapy, to increase weight loss. And collaboration really will likely result in better long-term weight loss, maintenance outcomes, and increased patient volumes really in both practices. We also talked about the endoscopist and bariatric surgery collaboration. Now, some bariatric surgeons are also endoscopists and will be doing these procedures themselves, but a lot of bariatric surgeons and endoscopists are separate, and there is definitely a role for both of these practitioners in a practice or in a collaborative referral pattern. So a bariatric surgeon may send patients to an endoscopist for management of weight regain or for management of complications. In addition, a patient may come to listen to a bariatric surgery seminar and decide they don't want to go to bariatric surgery. That patient may be a patient that might really be interested in endoscopic bariatric therapy. Likewise, the endoscopist may be seeing patients that either don't have sufficient weight loss with endoscopic therapy and they require to be referred to the bariatric surgeon, or there are patients that come to information sessions and decide that, you know what, endoscopic bariatric therapy really isn't for them, and they wanted to move to bariatric surgery. Just as an aside, in my own practice, I've found that probably about 10 to 15% of patients who come to my my endoscopic bariatric therapy info sessions ultimately decide that they want to go to bariatric surgery, and I refer them to my surgeon. So my practice really did increase my bariatric surgeon's volume. And again, collaboration will likely result in better care of patients and increase both endoscopic and surgical volumes. So that ends section 2, and section 3 will be reviewed by Dr. Marvin Yu.
Thanks, Shelby. So we're going to pivot and talk about endoscopic treatment of obesity. And the first lecture in this section was provided by Dr. Stephen Mundowitz from the University of Colorado, and he spoke of the FDA-approved devices. So currently there are 4 FDA-approved devices for primary endoscopic obesity therapy, including 3 intragastric balloons and 1 aspiration device that we'll talk about shortly. There is also an endoscopic suturing device, the Apollo OverStitch, that has FDA approval for the general indication of tissue apposition in the GI lumen, and is being used for endoscopic sleeve gastroplasty, but it does not have a specific FDA indication for primary obesity treatment. The first intragastric balloon, probably the one that has the most experience worldwide, is the Orbera balloon from Apollo. This is a saline-filled balloon with a fill volume of 400 milliliters to 700 milliliters. You need at least 400 milliliters to affect meaningful weight loss, we found. This is a 6-month implant indicated for a BMI range of 30 to 40. It does require endoscopy for both placement and for removal. It met the 2011 PIVI criteria for efficacy and safety is a primary endoscopic treatment, as well as for bridge treatment. Just to provide some detail on that, by these PIVI criteria for primary obesity intervention in class 2 and class 3 obese individuals, the device should achieve at least a mean 25% excess weight loss at 12 months, with incidence of serious adverse events less than or equal to 5%. So the Orbera balloon met these 2011 PIVI criteria. The next intragastric balloon that has received FDA approval is the ReShape dual balloon. This is also a saline-filled dual balloon system, with each balloon receiving up to a maximum of 450 milliliters of saline, so total fill volume maximum of 900 milliliters. So if you can imagine 2 medical grade silicone spheres that are connected by a flexible shaft, that's the ReShape dual balloon. This is similarly a 6-month implant, and it is also indicated for a BMI range of 30 to 40. Like the Orbera balloon, it also requires both endoscopic placement or endoscopy for placement, as well as endoscopy for removal. the efficacy of the ReShape dual balloon system was demonstrated in a randomized sham-controlled trial. The third intragastric balloon to receive FDA approval was the Obalon Balloon. So this has a different take on the balloon strategy. It eliminates the endoscopist from the placement step. So this is a system of 3 separate smaller balloons that are swallowed, and each balloon is filled to 250 milliliters with a nitrogen mixed gas. The balloon is swallowed in a capsule form, and the stomach location is verified using a combination of fluoroscopy and pressure readings. And balloons 2 and 3 are administered over a 9 to 12 week period. All balloons are removed 6 months after the first balloon is placed. This is also indicated for a BMI range of 30 to 40, and its efficacy was also demonstrated in a randomized sham-controlled trial. The AspireAssist is the only non-balloon device that has been FDA approved for endoscopic primary obesity treatment. This is a peg-like device that is placed as you would endoscopically a pull peg, and it allows aspiration of an estimated 25 to 30% of calories that are ingested. The pivotal randomized controlled trial in the US showed a 31% excess weight loss at 52 weeks. Complications are relatively minor and similar to PEG-related complications. Of note, patients with eating disorders were excluded from this trial. And also of note, the AspireAssist device has a counter which restricts the total number of aspirations. The mechanism of action seems to be multiple. In addition to the expected calorie diversion mechanism, there's also a change in eating behavior, specifically more careful chewing and more frequent drinking of liquids, which seems to contribute to overall weight loss. And then finally, in this lecture, the OverStitch was covered, the OverStitch by Apollo EndoSurgery. And this is a suturing device that is used to create an endoscopic sleeve gastroplasty. There are no randomized controlled trials for the OverStitch. The largest study is a multi-center study of 242 patients that reported a 15% total body weight loss at 6 months. Again, it's not a randomized controlled study, and only 22% of patients had weight recorded at 12 months, limiting the evaluation of durability. Next lecture in this section was provided by Dr. Rich Rothstein from Dartmouth Medical, and he spoke on consideration of other gastric devices. There are multiple endoscopic devices and procedures targeting the stomach beyond the strategies that I've outlined already that are currently in development and therefore not approved for clinical use, but you should be aware of what is in the pipeline. The first device that Dr. Rothstein spoke of was the Baronova TransPyloric Shuttle. This is a similar to a balloon, but not quite a balloon. It's a space-occupying device that is designed to intermittently obstruct the pylorus and therefore intermittently cause gastric outlet obstruction. It is also endoscopically placed and endoscopically removed. The original device in the original pilot study in Australia resulted in frequent ulcers and was therefore redesigned. And the most current iteration has been used in the US pivotal EndoBesity trial, which is a randomized sham-controlled trial that just completed enrollment. So more news to follow about the TransPyloric Shuttle. There's also the Spatz Balloon, which is a variation of the intragastric balloon strategies that I've talked about before. This is an adjustable balloon. So this is essentially a balloon that has a long, flexible, sort of deformable tether that is endoscopically secured to adjust the saline fill of the overall balloon. And the reason why the balloon is adjusted is to affect increased weight loss and also to manage the patient during periods of symptoms such as nausea or abdominal pain. This is a balloon that is it's slightly different from the other balloons in that it's seeking a 12-month implantation time. Probably will go for BMIs, similar BMI range of 30 to 40. It is currently under investigation in a U.S. multi-center FDA-approved trial. And of note, similar to the other balloons, this is endoscopically placed, endoscopically adjusted, and endoscopically removed. The other balloon that Dr. Rothstein spoke of was the Allurion ellipse balloon. So this balloon seeks to eliminate the endoscopist from both the placement and the removal steps altogether. So this is a saline-filled balloon that is swallowed in the form of a capsule. The stomach location is confirmed by fluoroscopy. This balloon has what's called a catastrophic valve release design at 4 months, such that it spontaneously deflates and it passes. It is currently under investigation in a European trial. Moving on to more sort of sci-fi type designs, there was discussion of the concept of a magnetically actuated balloon. So in conjunction with a swallowable balloon design, there's an external magnet that triggers an internal magnetic switch to combine acetic acid and bicarbonate to inflate the balloon. It's sort of an interesting concept. There's also a company based in Massachusetts called Gelesis. And this is a company that has designed a proprietary ingestible hydrogel in the form of a pill that patient swallows after meals, and the pill dissolves, and the hydrogel basically swells upon contact with water to over 100 times its original volume. So it's a space-occupying type mechanism. There are 2 types of Gelesis hydrogels currently being studied, something called the Gelesis 100 for weight loss indications and Gelesis 200 for type 2 diabetes. And this is currently under investigation in a FDA pivotal study. And then Dr. Rothstein also talked about endoscopic sewing devices, including the Apollo OverStitch, which I spoke of or covered in the previous lecture. But he also spoke of a USGI device or device from a company called USGI called the IOP. And so this is a steerable overtube that has 4 channels, which includes a channel for an endoscope, includes a tissue securing device, as well as a device that places full thickness tissue anchors for the purposes of creating tissue plication. And when used for primary obesity, this is called a pose procedure. And this company and this device recently completed its FDA trial. There was also mention of a device called a FullSense device. This is a modified gastroesophageal stent designed to provide expansion of the gastric cardia, which theoretically induces a sense of satiety. And this is currently under investigation in a European study. And then lastly, there was mention of Botox injection, which is usually injected in the gastric antrum and or pylorus. It's currently being studied in select centers, and the available evidence shows equivocal efficacy. So we're going to move on to the 3rd lecture in this series, provided by Dr. Christopher Thompson from Brigham and Women's Hospital, entitled Overview of Small Bowel Devices. So bariatric surgery has resulted in beneficial metabolic outcomes, and we know from these surgeries that the more extensive small bowel manipulation affected, the greater the effect on glucose control. And so these lessons from bariatric surgery have led to development of small bowel devices intended to treat diabetes, not so much weight loss, but more diabetes or type 2 diabetes through GI hormonal changes. The first device that Dr. Thompson spoke of was the EndoVators device from GI Dynamics. This is a duodenal jejunal bypass liner that has shown significant improvement in glycemic control in 5 multi-center randomized controlled trials. This is a device that's endoscopically placed. It's a liner that is 60 centimeters long that essentially bypasses the duodenum and the proximal jejunum, and it's anchored with a nitinol type mechanism with barbs at the level of the duodenal bulb. The US pivotal study was recently stopped by the company due to increased rates of significant adverse events, specifically a 3.5% rate of hepatic abscesses. And the company is currently engaged in discussions with the FDA to design a new trial. Some more news to come from GI Dynamics. Fractal is another company that's Massachusetts-based, and they have a procedure called the Revita procedure, which is duodenal mucosal resurfacing. And this is the idea of hydrothermal ablation of the duodenal mucosa of varying length segments, usually post-ampullary in the third and fourth portions of the duodenum. This device involves the submucosal injection of saline into the submucosal space to expand the submucosa, followed by a balloon mechanism, a balloon device that circulates hot water and uses hot water to ablate the duodenal mucosa. And the mechanism of effect is still relatively unclear, but in clinical trials, there's been a 6-month reduction in glycemic indices that have been demonstrated. Weight loss has been minimal. And the fractal Revita procedure is currently under investigation in European studies. The GI Windows device is a device that uses self-assembling magnets that are endoscopically delivered to create a partial jejunal ileal diversion. The system is called the IMAS, or the Incisionless Magnetic Anastomosis System. It entails the use of simultaneous upper enteroscopy as well as lower ileoscopy. And under fluoroscopic and endoscopic guidance, the self-assembling magnets are deployed in their respective lumens. They look like octagons, and they're coupled together, and that's the end of the procedure. Over 5 days or so, the magnets create a compression anastomosis. They are passed in the fecal stream, and this results in a side-to-side jejunal ileal diversion, or side-to-side anastomosis. A 10-patient pilot study was completed outside the United States and demonstrated significant glycemic improvement, as well as concomitant significant weight loss. 40% excess weight loss at 12 months have been reported. And the device is currently under investigation in a European study, and a second South American study is planned. And then just to mention some other small bowel devices, there is a company called Satisphere, which is a flow altering device. This basically looks like a nitinol C loop that occupies the C loop of the duodenum, and it has these mesh speed bumps, if you will, and it's designed to basically slow down the passage of chyme and to increase the contact of chyme relative to the duodenal mucosal surface. The mechanism of action is still ill-defined, but the results are ultimately theoretically anti-diabetogenic. And then another play on the bypass liner is the Lentex liner. This is similar to the endobarrier. This is a malabsorptive and restrictive liner that implants at the level of the GE junction, extends the full length of the stomach, bypasses the duodenum into the proximal jejunum. It's 120 centimeters long, and it's theoretically designed to recreate the malabsorptive and restrictive components of a gastric bypass. So data for this is forthcoming. We're going to move on to Dr. Barham Abudaye's lecture from Mayo Clinic, and he spoke on current reimbursement issues for bariatric procedures. Dr. Abudaye started with his own argument for endoscopic bariatric therapies, which is quite compelling. He spoke of the magnitude of weight loss is strongly associated with improvement in obesity-related comorbidities. The odds of clinically significant improvements in obesity-related comorbidities are much higher when the total body weight loss exceeds 10%. And he argued that many endoscopic bariatric therapies can achieve this threshold. Moreover, they are also anatomy preserving, they're reversible and repeatable. So there are many attractive features of endoscopic bariatric therapies for the treatment of obesity. There are currently two paths for reimbursement, namely insurance and cash pay for both primary and revisional therapies. And he argued that EBTs or endoscopic bariatric therapies will remain underutilized until reimbursement is provided from payers, both government and private payers. So with regards to insurance, at present, the process for obtaining insurance coverage is long and uncertain. And in his practice at the Mayo Clinic, this commonly involves a pre-certification justification and approval and a post-procedure billing submission that uses the CPT code of 43999. With regard to cash pay, the cash pay may apply to the EBT procedure alone, or may be part of a larger bundled payment for services, which would include pre-procedural evaluation, usually multidisciplinary in nature, including endocrine, psychology, dietetics, and GI. It would cover the EBT procedure itself, and it would cover the multidisciplinary aftercare that Dr. Sullivan spoke of for 12 months. The following components need to be considered in the bundle payment. This includes facility fees, anesthesia provider fees, professional fees, the cost of the device, and coverage of any medical complications. The last lecture in this section was provided by Dr. Sean Garber from NYU, and he spoke of apps and social media aiding in management of these patients. He defined telehealth as the use of electronic information and telecommunication technologies to support long-distance clinical healthcare. And he defined mobile health as the use of mobile and wireless devices for healthcare services. Now, both telehealth and mobile health are virtual platforms, and they may be most useful to maintain weight loss through comprehensive aftercare programs, which are designed to increase patient compliance with lifestyle changes in diet. And so these virtual platforms may provide a scalable, ongoing lifestyle modification reinforcement required to optimize results. These virtual platforms may be preferred by both patient and providers alike. For example, due to rising insurance costs, as well as opportunity costs, which is time away from work, travel, and parking. A majority of patients have shown that they prefer follow-up care through virtual visits rather than face-to-face visits. Moreover, telehealth and mobile health aftercare programs have been shown to be cost-effective for physicians. And the examples that he provided of mobile healthcare programs for both nutrition and fitness included Virtual Health Partners, MyFitnessPal, and Retrofit. So with that, I'll turn the mic over to my colleague, Dr. Nitin Kumar.
Thanks, Dr. Yu. This is Nitin Kumar, and I'll be discussing the nuts and bolts of reimbursement. And it started with running the gauntlet of regulatory approval for devices by Dr. Herbert Lerner, who is Senior Director of the Medical and Regulatory Affairs of the Medical Device Practice Group at Hogan Lovells, but perhaps better known as the former Deputy Director of the Division of Reproductive Gastrorenal Urologic Devices at the FDA. So he began with a discussion of the regulatory approval process, which is based on the risk of the device and the procedure. So 510K applies to low-risk devices. There's substantial equivalence to currently approved predicate devices. De novo devices are low to moderate risk devices, but there's no predicate. And where most EBT falls is a pre-market approval application or a humanitarian device exemption. These are novel technologies, they need clinical data, and they often require an investigational device exemption or an IDE, which allows the device to be used in a clinical study to get safety and effectiveness data. So risk begins with Class 1 lowest risk, which may be exempt from quality systems regulation, and these are very simple devices like tongue depressors. Class 2 moderate risk usually require a 510K. Some require clinical data. These are devices with predicates like endoscopes. And then Class 3 which are where EBTs generally fall, are the highest risk and require a PMA or a human device exemption. A 510K can apply to the U.S. introduction of a foreign device, and we saw this with the Orbera balloon, for example, or a significant modification of an existing device, and may require little or no clinical data. PMA, on the other hand, is rigorous. It needs an IDE, usually needs clinical studies, may go through panel meetings, and may require post-approval studies and post-approval monitoring requirements. The approval process can be difficult for these companies, which are usually startups in the endoscopic bariatric space. So Dr. Lerner recommended that these companies attend pre-submission meetings, review with the FDA their guidance documents, consult with the FDA about clinical study design, choice of endpoints, and sample size calculations. And many avoidable delays are simply due to a failure of communication. Additionally, he said that recent concerns include biocompatibility as well as cleaning, disinfection, and sterilization, given issues that we've had with duodenoscopes. The next lecture was the process for pursuing CMS payment, CPT, RUC, and RVUs by Dr. Glenn Littenberg, who is chair of the reimbursement committee and CPT advisor for ASGE. And he described the reimbursement process for a new EBT or any new device. So after FDA approval, the traditional pathway requires a CPT code. Additionally, a relative value scale or RVS update committee, which is called RUC, recommends relative value units to be assigned to each code to the Center for Medicare and Medicaid Services, or CMS. So CMS sets a final RVU and a payment for CMS. Now the CPT panel is entirely different from the RUC panel, which leads to complexities. So CPT code should reflect the procedure as it's typically performed, should be a device that has an FDA clearance, should be a procedure performed by many providers, and its clinical efficacy should be documented in literature. There are obstacles, and they are more significant than they were 10 to 20 years ago. The FDA has more stringent criteria for approval. The CPT technology assessment has more stringent evidence requirements for a Category 1 CPT code, which is really the type that companies want to go for. And for a fair RVS assessment, an RUC survey requires 30 valid responses, for which they have to send 100 to 500 surveys. Increasingly, CMS disagrees with the RUC, and this is leading to the question about whether RUC is an extra step. And private payers typically will not cover investigational devices or those without a CPT code. The process then is slow, complex, and it's highly political. Society representatives on the RUC are motivated to support a lower RVU for other specialties than their own. EBT, like ESD and POEM, which are other endoscopic procedures facing the same issues, some of the same issues, is an orphan procedure. And so most or all FDA-approved EBTs are currently self-pay. Some of them don't have CPT codes either. So this leads to alternative payment models, and some examples which you may have heard of. MACRA, which is the Medicare Access and CHIP Reauthorization Act of 2015, intends to transition medical care to a financial risk-bearing, clinically integrated system, QPP, quality payment program. And private payers are exploring a similar concept, medical homes, to bundle payments for episodes rather than fee-for-service. And so certain patients with obesity may have coverage for weight loss medications, EBT, and bariatric surgery under these models. Now, the way that EBT would fit into a model like these is assessing group outcomes, quality data, and cost data, and comparing them to untreated cohorts. And so this may allow a proof of benefit to a payer, it may allow extension of coverage for EBT, and it may allow distribution of shared savings to providers, payers, and patients in order to incentivize everyone to work at the same goal. And that may ultimately make fee-for-service and therefore CPT less relevant in the future. And finally, or rather third, we had integrating the evidence and stakeholder perspectives, the California Technology Assessment Forum by Dr. Jeffrey Tice, who is professor at the School of Medicine at UCSF, but also the senior medical advisor at both the California Technology Assessment Forum, CTAF, and the Institute for Clinical and Economic Review, or ICER. So he described the CTAF, which has been prominent in working with medical literature to provide information to payers and to patients, to providers about the value of healthcare services. So devices and diagnostics are not held to the same evidence standard for FDA approval as drugs are. And payers often rely on organizations like CTAF to perform additional systematic review. More recently, they've worked with ICER for cost effectiveness and budget impact analyses. So their technology assessment criteria, there are 5 of them, which they apply to any new technology such as EBT. The technology must have final approval from the appropriate government regulatory bodies, such as the FDA. Scientific evidence, preferably level 1 evidence, must permit conclusions concerning the effectiveness of the technology regarding clinically relevant or clinically significant health outcomes that matter to a patient. The technology must improve net health outcomes. The technology must be as beneficial as established alternatives, and clinical improvement must be attainable outside the investigational setting. Ironically, early FDA approval decreases the likelihood that good trials will be performed, and so longer follow-up is often needed after FDA approval in the post-market world to evaluate harms over the long term, and this is the importance of CTAF and its systematic reviews of literature. And finally, the insurer's perspective, what evidence and data are needed to merit payment, and this is from Opala Ernest, the Chief Medical Officer of Blue Cross Blue Shield of Illinois, and she gave us the perspective of the private payer. So EBTs are currently considered experimental or investigational by Healthcare Services Corporation, which owns and operates Blue Cross Blue Shield of Illinois. And this is a similar perspective to many private insurers at this time, and various bariatric surgeries may be considered medically necessary if the patient meets the criteria. So they have internal medical policies, which are eventually developed based on peer-reviewed publications and society guidelines, and they periodically review these publications and guidelines and reassess their criteria. This process allows experts and providers participation, and so they do encourage us as providers, they encourage academic physicians, they encourage researchers to participate in their criteria development process for what they consider experimental, investigational, medically necessary. Additionally, they utilize the same assessment criteria as CTAF for review of new medical technologies. And with that, I will turn it back over to Dr. Yu to conclude.
Thanks, Nitin. So to conclude, I would just like to reiterate the goal of the EndoVators Summit, which was to really gather obesity management experts, innovators, thought leaders representing various medical and surgical subspecialty societies, and key decision makers from all throughout industry, payers, and regulatory agencies to review the current state of the obesity epidemic in America, as well as to review the role that endoscopic bariatric therapies could play in the management of this chronic disease. One of the concrete results from the summit, we hope, will be a white paper attempting to summarize the discussions that you've heard from content experts. Additionally, video recordings of these lectures will soon be made available on the ABE website, and members will be able to review these lectures at their leisure to cover specific material in more detail. We anticipate the white paper will be published in multiple GI, endocrine, and surgical journals to help disseminate this, we hope, helpful information. Further, we hope that this summit will be a call to arms of sort for the various societies. We've identified multiple potential areas of joint cooperation, including uniting efforts to lobby payers, creating a shared registry, creating a joint training curriculum, educating our primary care providers to improve access to obesity care, and really working together to solicit research funding as well as to lobby Washington, D.C. So we hope that you've enjoyed this webinar and that you found the information helpful. We've certainly covered a lot of ground in a very short period of time. I'd like to thank all our webinar participants on behalf of my co-presenters, and specifically I'd like to thank Gina Steiner and Lyle Breams for hosting this webinar. So at this point, I'll hand it back to Gina Steiner.
So we want to thank you for joining us tonight. And before we let you go, I just wanted to remind you that we have some exciting events coming up next Friday, May 5th, at the Hyatt McCormick Place, Chicago, just before Digestive Disease Week. So that's May 5th from 1 to 5 p.m. We have the educational course, followed by a networking reception that evening right there at the same hotel. And we hope that you will stop by. You know, we'd love it if you could join us for the course, but if not, please come by the reception. For more information about these events and other activities of ABE, just go to bariendo.org. You can register for those free events there, and please feel free to contact me with any questions. Have a wonderful evening, and please feel free to take our survey that you'll receive after the webinar. Good night.